Today for EMN5, we're going to talk about Kawasaki's disease. And this is an acute febrile vasculitis, usually affects kids less than 5 years old. And the reason we need to recognize it is that it can result in these coronary artery aneurysms in up to 25% of patients if they go untreated. And these aneurysms can rupture, thrombose, stenose. Most of the deaths from Kawasaki's are actually from cardiac sequelae. And unfortunately, the cause is still unknown. But the good thing for us in the emergency room is that there's this pattern of signs and symptoms that we can look for to identify these patients. And if we can get them started on the IVI treatment right away, we can actually reduce that risk of coronary aneurysms down to 4%. So that's huge. So our goal in the ED is to recognize it, diagnose it, and get them treated. So let's talk about symptoms. So Kawasaki's is characterized by 5 days of fever and 4 out of the 5 of these other symptoms. And there's this little mnemonic, warm cream, that can help you remember. The warm is for the fever for 5 days, and then cream are the other symptoms. So we have a bilateral conjunctivitis, a rash, erythema to the palms and soles, cervical adenopathy, and mucous membrane involvement. Let's take a look at some pictures. So conjunctivitis, it's usually bilateral and without any exudate, as you can see here. The rash can be kind of variable. It's usually pretty diffuse, maculopapular, sometimes can be scarlatiniform, but sometimes looks more like erythema multiform. One thing that's helpful though is it tends to be a little worse in the groin, and you can even see this desquamation of the skin there. Now the erythema to the palms and soles tends to be kind of a firm, painful swelling, and 2 to 3 weeks later usually leads to this desquamation of the skin. It's actually pretty classic for Kawasaki's. We also have the unilateral cervical lymphadenopathy, and then there's the mucous membrane involvement. So we see this classic strawberry tongue, so bright and red, and then the lips can be really dry and cracked and red. And this is the classic timeline. We see the fever starts right away on day 1, and then the other 4 out of 5 symptoms also start in the first week. You can see that desquamation's a little delayed, and here's the aneurysms. So we have this little window of opportunity to start treatment before they begin to develop. Now, the tricky part is that not all Kawasaki's patients present with this perfect set of symptoms. We can have what's called incomplete Kawasaki's, where they only have some of the symptoms. But the problem is that those patients are still at risk for having the coronary artery aneurysms if they go untreated. We can also have what's called a delayed presentation. Maybe they come on week 2 of fever. And the problem is they already had a couple of these other symptoms, but they've resolved. And us as clinicians, we never see them because they're already gone. And it's easy to miss. So the patients that are high risk at being missed are those with an unexplained, prolonged fever. So they keep having fever and we have no other reason why. So make sure and think about, was this an incomplete or a delayed Kawasaki's? Maybe they've been treated for sepsis recently, but then the cultures came back negative. Maybe they were treated for meningitis, but the LP came back aseptic. The highest risk population for this happening is probably infants. So less than 6 months old, who've had a prolonged fever, no explanation, and haven't had the classic symptoms, have a high suspicion for Kawasaki's and go on to do the rest of the workup. So, luckily for us, if we're concerned about an incomplete Kawasaki's or maybe a delayed presentation, the AHA gave us this algorithm to help talk us through it. So this is for kids who've had fever more than 5 days, but maybe only 2 or 3 of the criteria. Or it's an infant who's had a fever for more than 7 days and no explanation. What we need to do is get an ESR and CRP. If they're elevated, we go on to get some more labs and maybe do an echo. And if those are positive, we have to treat them right away for IVIG. Now, if they have a normal ESR and CRP, we have to watch them very carefully. They need to keep coming back for serial exams, repeat lab values if the fever is persisting to make sure they don't develop an elevated ESR or CRP. And the other thing is if they have this classic desquamation, just go ahead and get the echo because that's very concerning. So the labs to expect for Kawasaki's are an elevated white count, anemia, and elevated platelets. We already talked about the elevated ESR and CRP. You'll also see white blood cells or pyuria for the urine. And if we're concerned, we go on to get the echo. And on the echo, we'll see coronary artery dilation or aneurysms. Mitral regurgitation is common. They can look for pericardial effusion. And all of these findings, they can plug into different criteria to make the diagnosis. But here's the catch. If you're worried about Kawasaki's, just go ahead and treat it. The echo should not delay your diagnosis, and just get the echo as soon as you can. Now, as we talked about, IVIG is the mainstay in treatment. You're going to give 2 grams per kilogram as an IV infusion, and you also add aspirin to this. Our goal is to treat the patients by day 10, because otherwise the risk of coronary artery aneurysm increases by about 3-fold. Okay, so let's review. We have 5 days of fever, combined with 4 out of the 5 other symptoms. But just remember, if you have an incomplete picture, they don't quite make the criteria, use the AHA algorithm, get an ESR-CRP to see if you should go on and do further testing. If you're concerned, you need to get an echo to help make the diagnosis and start treatment right away with IVIG. Here are the references, and thanks for joining us for EMN5.